I, Brittany, Alexandra, and Anne are going to be introducing you to Frank today. Frank is a 68-year-old white man with a diagnosis of right cerebrovascular accident of the internal carotid artery with left neglect. In addition, he has coronary artery disease and diabetes. 2 weeks ago, Frank was brought to the emergency department by his wife complaining of an unbearable headache with slurred speech and loss of control of his left side. He was admitted to the acute care hospital and was stabilized. After 5 days, he was transferred to the rehabilitation hospital for more extensive rehabilitation. Before his CVA, Frank had been a very active man. He recently retired from his job as a postal worker and is looking forward to traveling with his wife and tending to his garden. He's an avid gardener and woodworker and anticipates enjoying his two hobbies more extensively. Frank has a son from a previous marriage who does not live nearby and with whom he has a strained relationship. Frank and his wife live in a ranch-style home in a suburban neighborhood. There are 5 steps into the front door, and the garage is not attached to the house. They are friendly with some of their neighbors, but others are new to the neighborhood and they do not know them well. Frank has always done all of the maintenance tasks on his home. Frank's wife does the meal preparation and laundry. Frank will sometimes do the grocery shopping or go with his wife on this errand. He makes his own breakfast and lunch if his wife is not at home. Frank has many friends from the post office, and he has maintained his weekly bowling night with them after retirement. He and his wife have a strong marriage. They are planning on his return home after his discharge from the rehabilitation hospital. Their goal is for him to return home and resume his hobbies. He looks forward to picking up his life where it was before it was disrupted by the CVA. Frank's wife is supportive of these goals and will do whatever it takes to get him home to live life as before. Frank's plan of care is he will be seen by OT, PT, speech therapy, and recreational therapy. He will also be seen by nursing, dietary, and his expected length of stay is 3 weeks. During Frank's rehabilitation stay, we would address the occupations of ADLs, including dressing and bathing, IADLs, including care of others, home management, and meal preparation, and leisure participation, including gardening, woodworking, bowling, and traveling. These occupations would be prioritized by first starting with addressing his ADLs. Frank has dressing apraxia and left side neglect, making him max assist in all dressing tasks, and needs a great deal of verbal cues and physical guidance. It is important to help Frank become more independent in these ADL tasks. Next, we would want to address the areas of IADLs and leisure participation. Starting out his sessions would be with ADLs, then we would move into incorporating interventions to help him return to his home and resume his hobbies. Frank and his wife have a goal for him to return home and resume his hobbies, therefore he looks forward to picking up his life where it was prior to his CVA. With a client-centered approach to intervention, Frank's goals are prioritized during rehabilitation. During the ADL evaluation, Frank demonstrated difficulty with right-left discrimination and had a great deal of difficulty managing his clothing. Frank is max assist with all dressing tasks. It is noted that he appears to have dressing apraxia. Bathing, showering had to be completed at a sink, and he neglected the left side of his body completely. He required a great deal of verbal cues and physical guidance. Frank has deficits in perception, difficulty in figure ground and spatial relation, and demonstrates right-left confusion with a profound left neglect. During his daily routine, he showed cognitive deficits, including poor attention span, insight, judgment, and safety awareness. He has sensory deficits and weakness on his left side and poor dynamic sitting and standing balance. Frank also presents with decreased range of motion and coordination on his left side. These are obstacles for Frank because with left neglect and cognitive deficits, he is unable to figure out the front from the back or the sleeve hole from the neck hole. He is unable to release objects and finger extension is weak. With poor dynamic balance, Frank has to bathe at the sink and needed a great deal of assistance to complete his bathing task. As an OT, it is top priority to address Frank's wishes to return home and resume his hobbies. During treatment sessions, we will incorporate modified and adaptive ways in which we can help him return to those important hobbies and interests. For example, we can incorporate a modified gardening activity into his therapy sessions. An activity could include having Frank hold a larger spoon and dig rice and/or beans out of a bucket while sitting and plant beads or fake flowers made out of pipe cleaners. This one activity includes his hobby of gardening and addressing his cognitive deficits. attention span, sensation, left neglect, and upper extremity weakness. We can grade this activity up or down according to client needs, such as grading it up and having Frank practice dynamic standing balance while engaging in activity. Incorporating a modified woodworking and or bowling activity and working on endurance and dynamic balance for traveling. This intervention can also roll over into helping him with Adyls of dressing and bathing. Prior to his CVA, Frank's roles were a husband, avid gardener, and woodworker. He was also a postal worker. He was a very active man, but now he has many deficits that are creating a more sedentary lifestyle for him. He now lacks the strength, figure ground, and spatial visual relations and coordination to perform his key roles. Not being able to engage in these roles could lead to depression. He is unable to be independent and engage in husband duties. Although him and his wife have a strong marriage, this could potentially lead to marital problems. OT may assist Frank by helping him gain his strength and coordination back so that he is able to participate in his roles as a husband, avid gardener, and woodworker. OT may also assist with his visual deficits by working left side discrimination. Therapy activities can include modified ways and adaptive equipment to perform these roles until he is able to fully participate in them the way he used to. Key routines include a daily morning routine. He also lives in a ranch-style home and has always done all of the maintenance tasks. He will sometimes do the grocery shopping or go with his wife on this errand. He makes it his own breakfast and lunch if his wife is not at home. Frank shows cognitive deficits including poor attention span, insight, judgment, and safety awareness during his daily routine. With these deficits, they impact his routines by limiting his independence and completion in them. He now requires verbal cueing and physical guidance to complete tasks. OT may assist Frank in his daily routines by teaching him modified ways and used to complete each task. OT may also provide adaptive equipment for bathing, dressing, and eating, along with visual schedules and steps so that it creates an increased sense of independence and he is not relying on others completely to help him. 10 key performance skills that are negatively affected by Frank's CVA include stabilizing, reaching because of limited range of motion, manipulation because of tone and impaired sensation, coordination on left side for fine and gross motor, walking, handling, navigating because of left side neglect, endures because of his ability to complete a task without fatigue, flows because using smooth and fluid arm and wrist movements when interacting with objects, and searches locates. 10 key performance skills that are strengths is notices, responds, produces speech, looks, regulates, replies, heeds, expresses emotion, matches language, approaches, starts, and gesticulates. These strengths might be used during intervention to effectively communicate the tasks and activities at hand to Frank. He has no reported communication deficit and is amiable and likes the staff members. He teases them and is good at involving humor in interactions with others. To help set up Frank to bathe at the sink, we would have him sit in wheelchair or chair. Because of his seating position and limited reach, we would give Frank a reacher in which he could utilize to get all self-care items. All items could also be placed on the right side of his body for a better reach. If we utilize the left side by putting the items there, we would be focusing on his left side neglect. It could also be placed in a bin, basket, and set in his lap for easy accessibility. Tasks to be graded up as improvement is made. Frank would need visual cues for obtaining items from the left side. He would also need visual and verbal cues because of his cognitive deficits, poor attention span, lack of judgment, and safety awareness. By the end of 2 weeks, Frank will be able to attend the left side items in complete daily morning routine at sync with 3 verbal cues. We would give Frank adaptive equipment for his ADL because of his lack of coordination, left side neglect, and limited range of motion to reach items. We would give Frank a wheelchair for fatigue and a reacher to be able to dress himself and reach items that are too far for him. A cognitive aid could also be given, such as step-by-step instructions, visual and or speaking reminder to aid him in following steps and completing the task without being distracted. To address Frank's left neglect during his ADLs, objects needed to perform ADLs can be placed on the left side of him to remind him to return in that direction. Adaptive equipment can be utilized for reaching. Intervention activities include dressing, bathing, and toileting. Activities outside of the ADL routine include modified woodworking with tools on the left side and modified gardening with tools on the left side. To address Frank's dressing apraxia, we would use repetitive task practice, mirror therapy, and adaptive equipment to increase his independence. A step-by-step verbal and physical cueing can also be done. Here we created an instruction sheet for Frank to follow for his morning ADL routine. The instruction sheet includes making his bed, taking a bath or shower, putting on clean clothes, applying deodorant, brushing his hair, shaving, eating breakfast, and then brushing his teeth. As Frank completes each activity each day, he is able to check it off so that he knows he has completed each step. For his morning routine intervention activity to do with Frank, because it is something he used to do as part of his routine, we would want part of making his wife's morning coffee that is part of his role as a husband to be incorporated. By incorporating meal preparation into his intervention sessions, we as OTs are focusing on Frank's goal of returning to his life prior to his CVA. This is also a client-centered, meaningful activity, which means he is more likely to engage in the intervention and have client satisfaction. Safety measures are always our first priority when addressing any intervention. For Frank, when doing the kitchen activity, we want to make sure that items are not too hot or too cold. There are no items that he can trip on. All surfaces and countertops are an appropriate height. He can easily reach things without knocking things over. Create a simple step-by-step sheet for making food. Make sure sharp items are out of reach, and make sure that he can tolerate activity seated and or standing. Considerations in staff education include putting items within reach and on opposite side of visual neglect, so putting items on the right side of his body, reminding the staff of the client's affected side, educating them on his figure ground discrimination deficit, and consideration of cognitive deficits, lack of judgment, and safety awareness.
Okay, so now we're going to move on to the client factors portion. So first off, we're going to identify and prioritize Frank's neurological deficits. So these would include impaired sensation in the left upper extremity, a balance impairment, deficits in perception, including difficulty in figure ground and spatial relations, poor attention span, insight, as well as insight, judgment, safety awareness, and right-left confusion. And the interventions activities that we would use to reduce the muscle tone in Frank's upper extremity and trunk should include the use of the affected side. Intervention activities that could be done are weight-bearing activities, stretching for passive range of motion, mirror therapy, functional electric stimulation, bilateral training, mental practice, and perhaps even splinting of his affected upper extremity. And the way we would incorporate purposeful activities into the intervention plan would be that the therapist must first know what the client needs and wants to do. The activity that they have them doing has to hold meaning for the client and can be integrated into his daily routine. So in the example of Frank, he really enjoys gardening, so that could be incorporated into his intervention plan. And we would fabricate a splint for Frank's upper extremity. We would most likely choose a resting hand splint to facilitate keeping Frank's upper extremity in an open position since his finger and wrist extension is weak. The splint will help keep his fingers open in addition to keeping the thumb out of the palm. We would begin the wearing schedule with Frank wearing the splint at night for approximately 6 to 8 hours, and if needed, he can begin wearing the splint a few hours a day as well once he has increased his tolerance to the splint. Ultimately, we feel that a splinting intervention has the potential to reduce the amount of stiffness that Frank experiences and prevent muscle shortening and contractures. So in terms of Frank's cognitive and perceptual deficits, because of that he is experiencing both of these, he may have difficulty with dressing by being unable to figure out which shirt hole is for the arms and which is for the neck. His difficulty with figure ground discrimination can affect all aspects of his daily activities because he may not be able to obtain materials he needs for certain tasks. His cognitive deficits can lead to more injuries while participating in daily activities due to his poor safety awareness, which necessitates moderate verbal cueing. So the functional activities that we would use to address Frank's cognitive and perceptual deficits would be through activities that are valued by Frank, such as gardening, cooking, and arts and crafts activities such as woodworking. Gardening gives Frank the opportunity to be outdoors and can even improve his endurance, balance, and coordination. It will also challenge Frank's perceptual skills and could be a beneficial approach to help him attend more to his left side. Simple cooking activities would allow the therapist to work with Frank on some of his cognitive deficits with an emphasis on safety. Woodworking would also help work on his safety awareness and also requires attention, problem solving, memory, and sequencing skills on top of the gross and fine motor skills needed to complete this activity. Upon successful participation in these activities with modifications as needed, recreational activities such as bowling may be incorporated into therapy so that you can continue to expand upon proper body mechanics, safety awareness, and other cognitive and perceptual skills that still need improvement to optimize Frank's occupational performance. So in terms of the preparatory activities or occupation-based intervention methods that we would use to address Frank's cognitive and perceptual deficits, we may start off with a simple word or image search. We may have him do a puzzle, or even have him use high contrast for modified woodworking interventions. We would also ensure appropriate lighting in the room and help Frank locate all tools and objects needed prior to tasks so that he knows where they are while engaging in the activity. We would also walk through safety steps with Frank prior to engaging in intervention activities and highlight any sharp points on tools with tape. And some of the primary safety concerns that should be addressed with Frank are his lack of judgment, lack of safety awareness, poor memory, and figure ground discrimination difficulty. So to help avoid any of these potential risks, we would eliminate tripping hazards, put high contrast tape on steps, objects, and sharp tools. We would repeat safety steps with Frank and have him repeat them back to us. We would give him visual handouts of steps for memory, and we would make sure that Frank is supervised during all interventions until progress is made. And then some ways to support Frank psychologically would be to help him deal with his decreased abilities through positive reinforcement, praise, and motivation. It is also important to encourage Frank and support his family as well. We want to build rapport with Frank so that he trusts us during his stay and inspire him to want to continue working hard and improve. So some of the types of adaptations to the environment or adaptive equipment we could use to address the safety concerns we have already identified include providing a shower chair or tub bench, reducing clutter, eliminating tripping hazards, using high contrast tape for figure ground discrimination. We could also have him use a reacher for dressing, a long-handled scrub brush for bathing, and a wheelchair or rolling walker. We also believe that Frank would be a good candidate for using an assistive device to help him resume his Adyls because it will allow him to be more independent. For example, a reacher could be used to help with dressing and reaching for various things because of his decreased range of motion. A tablet could also be helpful by setting reminders on when to perform certain Adyls and downloading apps that are easy to use and will provide step-by-step information on how to perform things like dressing, personal hygiene, and personal device care. Frank may be using humor as a coping mechanism to hide the feeling of being afraid or disappointed about his current situation. In order to deal with it, I would address the situation with Frank because there may be an underlying mental health condition that needs to be addressed as well. This can be addressed at the end of the session by asking him questions about how he felt during that specific intervention and having open communication with him. Some of the concerns that Frank may have relating to his loss of function would relate to the fact that since Frank was very active prior to his stroke, one of his concerns might be not being able to participate in things that he used to like working in the garden, woodworking, home maintenance, bowling night, and grocery shopping with his wife. He might also be concerned that he will not be able to be an active participant in his marriage in regards to these areas and will be more reliant on his wife for ADLs and IADLs. So we would include Frank's wife in the patient family education because she should be included so she will have an understanding of Frank's condition and ways she can help him. The areas Frank's wife should be educated on are his ADLs as well as education of his precautions and strategies to help Frank's safety awareness and also his splint wearing schedule if applicable. The therapist should also take time to discuss ways that Frank's wife can promote use of Frank's affected side at home to further therapeutic gains. And to educate his wife, during Frank's therapy sessions, his wife would be there with him so that she can understand and perhaps demonstrate how to take an active role in Frank's progress. In terms of educating her in assisting with Frank's ADLs, this can be facilitated by an instruction sheet created for his morning ADL routine. The therapist can educate his wife on how to walk through this instruction sheet with Frank to make sure that he completes each component of his routine. The ADL education might also entail the therapist explaining possible activity modifications or energy conservation techniques. To educate Frank's wife on safety precautions, the therapist may list all of them and have his wife observe certain interventions with Frank where safety has been a concern so she can identify when some of these issues may arise. This way, she can identify potentially dangerous situations before they arise and she can facilitate safe performance accordingly. Additional education on splint wearing schedule can be done by providing Frank's wife with necessary visual aids and having her demonstrate how to help Frank don and doff the splint. The therapist can also educate Frank's wife on hygiene and how to identify problems with fit, since those should be brought up to the therapist immediately. In discussing ways that Frank's wife can promote use of his affected side at home to further those therapeutic gains, the therapist can provide some examples and send Frank's wife home with a visual aid or form with ways to promote use of the affected side. So to work with the team to educate Frank on safety issues, we would make sure the team is on the same page about the safety issues to address and are telling Frank the same things in order to stay consistent. The team should be educated on the deficits and safety issues identified so that they can look out for potential problems accordingly. The team needs to be aware of what activities can create potentially dangerous situations so that they can take extra precautions and give special attention to pointing out safety issues to Frank and correcting each of them with him as they arise. So in terms of social supports and how we can incorporate them into intervention, Frank has many friends from the post office, all of whom he stays in contact with and plays bowling with weekly before his CVA. To incorporate them into the intervention session, he could FaceTime or video call with some friends while he does an activity, or they could attend a session as well that could be geared towards an activity they like to do together. For example, during a therapy session, a plastic bowling set could be used to simulate the bowling nights Frank has with his coworkers, which allow him to participate in bowling at this point in his recovery due to the weight modification of the equipment. Going through the motions required for activity participation with the support of his coworkers and the modified equipment can improve Frank's feeling of self-efficacy and support further therapeutic gains so that he can potentially return to bowling nights with his coworkers long term.
One theory or frame of reference that we would use for Frank is the model of human occupation. We chose to use the MOHO to help us develop an intervention plan because it utilizes a top-down approach by looking at the person and their meaningful occupations and their relationship with the environment. The MOHO is a good model to demonstrate how occupations are motivated, in addition to how they're incorporated into the person's performance patterns within the context of their environment. Motivation should be a key component in intervention planning to facilitate occupational performance and organization of that performance into habituation of habits, roles, and patterns, which is largely affected by the environment. An evidence to support the choice of theory or frame of reference is the study titled The Model of Human Occupation-Based Intervention for Patients with Stroke. A randomized trial examined a group of individuals who had experienced a CVA. The MOHO-driven OT intervention was compared with interventions based on other theories. Study found that experimental groups significantly improved in ADL and QOL scores following MOHO-based OT interventions, and scores were actually than before the practice. When compared to the control group, the experimental group had significantly improved on ADL, all 5 domains of quality of life, 26, physical functioning, bodily pain, general health perception, and social functioning. A theory or frame of reference you'd use to remediate Frank's neuromusculoskeletal deficits. For one of them, it would be the biomechanical frame of reference, which can be used to remediate Frank's neuromusculoskeletal deficits because it focuses on impairments or deficits that are limiting occupational performance. Assumptions for this frame of reference include that the client is able to acquire voluntary motor skills necessary for occupational performance, or that the underlying problem affecting occupational performance can be remediated with intervention, resulting in subsequent improvements in occupational performance and participation. The goals of the frame of reference are to prevent deterioration and maintain existing movement, restore movement for occupational performance, as well as compensation or adaptation for lost movement. All of these goals are important for Frank since he needs to use his affected side and learn to position himself to prevent possible neuromuscular deficits such as muscle atrophy and contracture, as well as to promote increased range of motion, muscle strength, endurance to promote optimal occupational performance. Assessments that align with this frame of reference include standardized objective tests of occupational performance, pain scales, examination of skin or wounds, and sensory testing. Interventions that align with this frame of reference include ADL retraining, work hardening, static and dynamic orthosis, active assistive and passive range of motion exercise, and nerve gliding. Some problems that Frank faces are problems with perception, difficulty in figure ground and spatial relations, confusion with right and left, profound left neglect, cognitive deficits with poor attention span, insight, judgment, and safety awareness, impaired sensation for light touch and sharp dull, impaired stereognosis on the affected side, no active range of motion in the right upper extremity, weakness in the left upper extremity and lower extremity, poor dynamic sitting balance and standing balance, range of motion deficits, more marked increase in tone throughout the upper extremity, neck, and trunk, weak finger extension, coordination of left is impaired for fine and gross motor, max assist with all dressing tasks. Some strengths that Frank has includes good social interaction skills and good communication skills. These can be utilized because Frank is able to communicate his self-goals as well as communicate when he is in pain, tired, or needs help. These skills also reveal a positive emotional aspect of Frank, meaning that he is less likely to reveal frustration quickly during intervention, and he can express himself to his therapist. One functional assessment to evaluate Frank's lower extremity and upper extremity use is a Fugl-Meyer assessment. This assessment was chosen because it can assess the client's upper extremity and lower extremity performance in ADLs, functional mobility, and pain. It is also a stroke-specific assessment. This assessment will provide information on motor function, sensory function, balance, joint range of motion, and joint pain, which are areas of deficits the client has. Another functional assessment that can be used is the Katherine Bergo scale, which is a short scale that is performance-based and designed to measure the presence and severity of unilateral neglect during everyday life situations. This assessment was chosen because it has an observational and self-report component to compare the patient's awareness with the therapist's assessment, which helps to identify problem areas to target when intervention planning. One of his long-term goals would be, by the end of 3 weeks, client will perform upper body dressing independently with adaptive equipment as needed. Intervention planning would potentially address client's deficits in perception, primarily with figure, ground, and spatial relations. It would also address his right-left confusion and profound left neglect. Another long-term goal would be, by the end of 3 weeks, client will perform bathing independently with shower chair and other adaptive equipment as needed. Intervention planning would once again address client's right-left confusion and profound left neglect. Intervention planning could also potentially incorporate some balance training to improve his dynamic sitting and standing balance as Frank transitions from bathing in a chair at the sink to ultimately sitting or standing in the shower. Intervention planning should also target his left upper extremity and lower extremity weakness for more optimal occupational participation. And his last long-term goal would be, by the end of 3 weeks, client will perform simple gardening tasks independently with adaptive equipment as needed. Intervention planning would once again address client's right-left confusion and left neglect, like tending to items on the right and left side, in addition to dynamic sitting and standing balance. Proper tool use could be incorporated into the intervention planning as well to strengthen the upper extremity, and safety training can also be implemented so that Frank can participate in this valuable leisure activity while minimizing safety concerns and risk for injury. For his short-term goals, to address the long-term goal of upper body dressing, his first short-term goal would be, in 1 week, client will identify neck hole from arm holes correctly with one visual cue. Second short-term goal is, in 1 week, client will don pull-over shirt with mod assist. Third short-term goal is, in 2 weeks, client will don pull-over shirt with min assist. To address the second long-term goal for bathing, the short-term goals would be, in 1 week, client will attend to bathing materials on the left side of the sink at least 50% of the time. In 1 week, client will bathe seated at sink with mod assist. And the third short-term goal would be, in 2 weeks, client will bathe with min assist and use of adaptive equipment as needed. For the third long-term goal of simple gardening tasks, the first short-term goal would be, in 1 week, client will attend to gardening supplies and plants on his left side at least 50% of the time. The second short-term goal is, in 1 week, client will perform simple gardening tasks, like watering his plants or seeding, using his left upper extremity with mod assist and adaptive equipment as needed. And for the third short-term goal, in 2 weeks, client will perform simple gardening tasks, like watering his plants and seeding, using his left upper extremity with min assist and adaptive equipment as needed. If Frank and his wife have unrealistic long-term goals, the therapist can explain to the client and his wife where he is at right now in his condition and explain the progress of recovery. The therapist can then guide the client into making a goal that is meaningful and realistic with the help of the client and his wife. Some obstacles Frank may face in reaching his stated goals is a lack of motivation, not progressing, and not practicing outside of therapy sessions. He also exhibits cognitive deficits that affect his ability to complete his daily routine due to the presence of poor attention span, insight, judgment, and safety awareness. The CODA delivers services under the supervision and partnership with the OTR. During the evaluation process, the CODA, if directed by the OT and deemed competent, can perform designated assessment to contribute to the evaluation, however, are not allowed to interpret the data. During the intervention planning, the CODA, along with the OT and client, collaborate to create a plan. The CODA is responsible for being knowledgeable about the results of the evaluation and providing input into the intervention plan. Lastly, during the intervention, the CODA can implement interventions under the supervision of the OTR. An assessment that would expand upon observations of Frank's left-sided neglect is the baking tray task, which assesses unilateral neglect and takes little time to administer, while also being fairly inexpensive. The therapist provides a setup of 16 cubes and a tray where he or she can measure the cubes. With no time limit, the client are required to use all cubes and are reminded until all have been distributed if any are omitted. Other occupational performance assessments may include the EFPT to determine what executive functions are impaired, if any, an individual's capacity for individual functioning, and the amount of assistance necessary for task completion. The EFPT is a great way to measure what the client can do and not what they cannot. The KELS may also be administered because it measures the client's ability to live independently at home and in the community and tests to see if the client is aware of potential safety concerns. The Judson-Taylor hand function test may also be utilized to assess the ability to use the hand in functional tasks, which would apply greatly to Frank since he wishes to return to his desired leisure activities of gardening and woodworking. The activity card sort would be a good assessment tool to measure client participation since it elicits level of participation in the areas of instrumental ADLs, low demand leisure activities, high demand leisure activities, and social activities, and whether recent changes in health or age have affected participation in activities. We chose a variety of assessments for Frank, with the Fugel-Meyer being more client factor, body function level, in addition to other assessments aligning with a biomechanical frame of reference, such as standardized objective tests of occupational performance, pain scales, examination of skin or wounds, and sensory testing. The Katherine Bergo scales, the baking tray task, EFPT, KELS, and Judson-Taylor hand function tests are occupation-based assessment that can help assess occupational performance to enhance client participation in valued occupations. The ACS is a participation level assessment tool that will help us navigate how to reintegrate Frank into the community. Frank has regained active range of motion of 15 degrees in all motions of his upper extremity. The intervention plan can be modified by grading up the intervention activities and tasks. As Frank continues to regain range of motion, we want to adapt these so that he continues to work towards his goal of returning back to his normal life prior to his injury. Because of the 15 degrees of active range of motion regained, Frank would have less difficulty performing ADLs and other activities. For example, when it comes to dressing, he's going to be able to don and doff upper and lower body clothing. Frank is making progress in reaching his upper body dressing long-term goal. During bathing, he will more easily be able to clean hard-to-reach areas and require less assistance. For leisure activities, Frank will be able to perform these activities at a higher satisfaction level because he is able to engage in them more and more as he used to. You walk into Frank's room in the morning to work with him on ADLs and find him in bed with the bed rails up, but trying to climb over them. He already has one leg over the bed rail and is trying to get his left leg over now. As Frank's therapist, I would walk in and nicely ask him to stop what he's doing. I would move the leg that is over the rail back over to the bed and ask him to patiently wait while I drop the bed rails down. Then we would properly transfer him out of the bed. This is important because your number one priority is safety. We want to make sure that Frank does not injure himself even more and want to utilize the room equipment the way it is meant to be used. By doing this, we are teaching Frank to utilize correct body mechanics, posture, and the equipment correctly to best help him with his mobility. During an intervention session in the OT kitchen, Frank is making a cup of instant coffee. He turns on the stove, gets the kettle, and takes it to the sink to fill. He starts the water, notices a sponge, and starts to clean up the area around the sink itself, and the outside of the cabinets around the sink. He has forgotten the stove and the kettle and has left the water running for 5 minutes during his cleaning. The cause of this behavior may be from his cognitive deficits, which includes poor attention span, insight, judgment, and safety awareness. In order to refocus Frank, the therapist can remind him about the task of making a cup of instant coffee, then ask him to repeat the steps of the task he is to do. He can then be guided to the kettle to remind him of the task. The future kitchen activities should be adjusted by limiting the amount of clutter in the kitchen to prevent distractions and simplifying the task. Another way the kitchen activities can be adjusted is by providing a visual aid that shows a step-by-step instruction on what needs to be done to complete the task. As each section of the task is completed, Frank can check it off the list. Frank is in the middle of dressing himself. He has been following a set of cards with the steps for dressing on them with good results. Today, Frank is not attending to the cards. He starts to get up to leave the room, but only has his boxers on. In order to redirect Frank to his dressing task, the therapist can stop him and ask him to look in the mirror and ask, "Does something not look right?" Then give him the set of cards with the steps for dressing. The therapist can then go over the steps with Frank and remind him he is still missing clothing. From there, we would then start at the beginning of the steps and go through them together to make sure the task is completed prior to Frank leaving the room. During functional mobility, Frank has progressed to ambulating with a hemi walker and supervision. However, he bumps into objects on his left side, the door frame, the bed, and the dresser. To address this, I would suggest putting bright colored tape on the left side of the objects in his room and teaching him visual scanning techniques. During the intervention session, the therapist would sit at his affected side to cue him to look in that direction. The therapist can also do activities that encourage Frank to reach towards the affected side and cross midline, like gardening activities. Frank is being discharged home. He now requires supervision for dressing and bathing using his cue cards and equipment. He continues to be impulsive and has poor insight into his deficit, and the carryover of new learning requires frequent repetition. He can use his left upper extremity to stabilize objects, but gross and fine motor coordination are still poor. He continues to have left neglect and has difficulty compensating for it. A service we would recommend for Frank is home health care agency, which may be needed because of Frank's need for skilled service to improve his deficit. The home health OT can offer strategies to manage his daily activities while reducing the risk of injury. Frank still has significant deficits in executive functioning, including impulsivity and insight, so careful attention will need to be given to ensuring he increases his safety awareness and is able to comprehend information and instruction that is given to him. Home modification may also be warranted to help compensate for his left neglect. Another is the outpatient therapy services, which may be recommended to work on upper extremity strengthening so that he can improve his gross and fine motor skills. Further intervention to treat unilateral neglect can be included in the intervention plan to assist in motor planning and gross and fine motor coordination as well. ADL training is also warranted given Frank is still at a supervision level and would like to become independent. So this would be an example of a referral for Frank for the home care agency, which we'll be seeing him next. So it includes his name, address, date of birth, when it was received, the other professions that are involved, the referral source, primary diagnosis, relevant medical history, the problem list and reason for referral, his home situation, house type, and any potential risk for staff visiting. Discharge instructions that can be given to Frank's wife include safety concerns due to his continued poor insight into his deficits and difficulty compensating with left neglect. She may also need instructions on how to use adaptive equipment that Frank uses in order for her to improve assistance when needed, and possible home modifications to help Frank be more independent, like placing bright colored tape on corners of furniture and placing grab bars where necessary. Lastly, information on where Frank needs the most assistance can be discussed.
Thank you for listening to our presentation on Frank.